Hello, everyone. We're here today with GU Oncology Now with the ASCO Bladder roundtable discussion. My name is Vadim Koshkin. I'm a GU medical oncologist at the University of California, San Francisco, where I help co-lead the bladder cancer program for the medical oncology side. And we have a great panel with us here today, and I'll let the panelists introduce themselves, starting with Matt.
Hi, I'm Matt Zibelman. I'm an associate professor of GU Medical Oncology at Fox Chase Cancer Center in Philadelphia and director of clinical research of the GU service line.
Hello, my name is Cora Sternberg, and I'm a genitourinary oncologist and professor of medicine at Weill Cornell Medicine. I'm also the clinical director of the Englander Institute for Precision Medicine at Weill Cornell. Happy to be here.
Hi, I'm Dr. Dan Petrylak. I'm professor of medicine and urology at the Smilow Cancer Center, Yale University, and happy to be here as well.
Great. Well, again, a wonderful panel here, and our topic here today is really the treatment strategies for advanced bladder cancer. And now, sort of switching gears completely, we've discussed how most patients, as their first, probably and second line of therapy, receive platinum-based chemo, and then usually a checkpoint inhibitor, and then of course now we're introducing enfortumab and pembrolizumab. Upon progression on any of those regimens, how do you select the next option to give them, and what are your general approaches?
We try to sequence patients, first of all. We try to look for FGFR mutations to see if they're eligible for erdafitinib. And if they're not eligible for erdafitinib, we go to sacituzumab govitecan, which, as you said, is also approved for triple-negative breast cancer. It's another antibody drug conjugate with completely different toxicities than EV. It doesn't have neuropathy or hyperglycemia. It does lower the blood counts, and patients get diarrhea. So the side effects are a little different, but we've seen responses in those patients after enfortumab vedotin. In patients where I can't give erdafitinib, I would prefer to give erdafitinib if I could, but there's like 1 in 10 patients that are really FGFR mutated.
And Dan, is that your approach?
Yeah, that's my approach. I mean, I think it's important to get the testing for FGFR early, especially at the beginning of the process when you're treating a patient with metastatic disease, because you want that information available if the patient does progress. And rather than waiting the time to get the test done, it's just simply better for the treatment decision to have that at hand. So we look for FGFR mutations. That's one thing. Of course, clinical trials are important in this situation as well. And I think now we're seeing, it's almost like the deck is being reshuffled. You know, we're seeing some of the later line treatments being moved up earlier. And then how's that going to affect the sequencing later on? We don't have any good answers in terms as to whether something is better or not, whether you should select sacituzumab, or if they're FGFR positive, sacituzumab over erdafitinib or erdafitinib over sacituzumab. There is some data that's being presented at this year's ASCO meeting called Thor, and this looks at erdafitinib. It's a randomized trial versus standard of care chemotherapy, docetaxel, vinflunine in Europe, or paclitaxel, and found that in this trial that there was about a 5-month improvement in overall median survival and an improvement in progression-free survival. The objective response rate of erdafitinib was very similar to what that was seen in the phase 2 study. So it's a viable option for these patients, and certainly should be considered. But the problem is it's only about 10% overall, but we need to look for it.
Yeah. We don't really know the right sequence either to give erdafitinib before EV, or, if we're going to give it before. But if I find that they're FGFR mutated, I think that from the little data I've seen in phase 2 that I give the erdafitinib before EV even.
Well, there are a lot of subtleties to this, because there may be a difference between the FGFR2 fusions versus the FGFR3 mutations. That's one thing I think that's important for us to look at in the future. The other issue, too, is there a change in the immunogenicity that's after in somebody who's been treated with erdafitinib? There actually may be more of an immune effect, and we're going to see a presentation at this meeting from Marlene Sifaraki looking at the combination of erdafitinib with a checkpoint. We all thought that this meant that these were resistant to checkpoint therapy, but it may actually be that there may be a biological change that the erdafitinib is having in terms of the tumor microenvironment that may make them more susceptible to immune treatment.
Yeah, absolutely. What you're referring to is, of course, the Norse study that Eileen is presenting. And there I believe its response rate is around like 70%, right, if I recall correctly, to the combination of checkpoint inhibitor and erdafitinib.
Platinum ineligible.
And platinum ineligible, yeah.
Combination.
Yeah, so frontline patients, but again, very comparable to what we see with pembrolizumab and enfortumab, the population we were extensively talking about just now, and certainly higher than erdafitinib alone, which is around low 40s. But yeah, I mean, certainly exciting data and another way to sort of individualize treatment.
It's interesting to see the differences between urothelial cancer and clear cell carcinoma of the kidney, where you have these great combinations with TKIs such as lenvatinib and pembro, which really failed pretty miserably in platinum ineligible patients with metastatic bladder cancer. But here I think this may be the change that we're seeing, that the targeted therapy combined with immune therapy may actually have a role now in urothelial carcinoma.
Absolutely.
I think to your point, it also shows the difference with lung cancer, where combinations with chemo and immunotherapy have been effective, and they're really now dicing up lung cancer into so many different mutations, and we're not unfortunately quite there yet in bladder cancer. I think FGFR in that population is the one that we have, at least for now. And I think the other exciting thing is there are future sort of next generation FGFR targeted drugs that are along the way that hopefully will offer even better responses as well as decreased toxicity, because erdafitinib certainly has toxicities. Patients don't love being on it. They're fatigued, anorexic, hyperphosphatemia is an issue. And so it's not the easiest drug to give or take. And so hopefully future drugs will improve on that.
Yeah. Well, Dan and I worked on a study with rogoratinib. It was an interesting drug, but there was a problem with validating the marker, and they were using mRNA, and there was a problem with the marker, and they stopped the trial because it wasn't positive, and I think in breast cancer, so the whole trial was stopped in the beginning. So they have to validate a marker better of what we're looking at for the mutations.
It also lends the question, what's the best test to look at FGFR? That study, there was a response difference seen in the FGFR3 DNA mutations. But when you looked at the RNA for all the FGF subtypes, you didn't see the difference. So again, as Cora was saying, the test that we use to select may be actually very, very important to the outcome we have.
It originally was done with immunohistochemistry, and then when they redid it with another company, it was different. And then when they did it with, which wasn't part of the study, with next generation sequencing with the DNA mutations, those patients really did have a benefit, but that wasn't the plan of the study.
Yeah. So biomarker, the correct biomarker is key. And it seems that really,
biomarker is key, and validation of the biomarker is key, and companion biomarkers with our drugs is key, and that's part of the reason we've had so much problem with all these, markers looking at PD-L1 and different companies having, results one way one day and one day a different day. And I find it also difficult, as you do, that in lung cancer patients, the combination of chemo and immunotherapy works, but it doesn't work in urothelial cancer. And I think it just has to do with the design of the trials and getting unlucky with all those, the way trials were designed.
It also could do with could be related to the biology. If you look at the positive trials in urothelial carcinoma that were randomized, we have the nivolumab trial as adjuvant, where the benefit seems to be in those patients who had prior chemotherapy, the neoadjuvant treatment. Then we look at switch maintenance. These are a selected group of patients that whether the chemotherapy is changing the biology is not clear. And then finally, the Merck study that looked at pembrolizumab and got it approved compared to chemotherapy. None of the other trials were positive. And now, so is that because there are different checkpoints that were used, or is that because something biologically is going on different with this tumor type that pre-treating with chemotherapy changes the microenvironment that makes it more susceptible to immune treatment? A lot of great questions to ask from this.
And to that point, does the chemotherapy matter? We've done all of these studies in urothelial cancer with gemcitabine, platinum-based combinations, which is not the drugs that have shown benefit in combination in lung cancer. Does that have something to do with it? We don't know the answer to that.
Why? And this, I think, is really an important question. If you look at the data with cholangiocarcinoma, where they've given GemCis plus a checkpoint and shown superiority of that combination, yet you don't see that with urothelial carcinoma. So that's, again, pointing to the biology.
Mm-hmm.